we can say there is a reduction of the intensity of the psychosis and the degrees of its evolutive potential. However, the effectiveness of chemotherapy varies according to the clinical and evolutive forms of schizophrenia.
Perhaps the heart and the pacemaker and the conduction system of the heart can be looked upon as a very simple model of those structures that we now discuss. That's the striatum and the limbic system.
The principles of management in schizophrenia are relatively simple, but they require the acquisition of skills that some psychiatrists, some nurses, occupational therapists, social workers do not now possess. And above all, they require a willingness to learn from patients.
One of the things that he has found is that those adoptees who became schizophrenic without a known genetic load in their biological families have a very high history of birth injury or brain injury soon after birth, encephalitis, concussion, and so forth, as compared to the probands who developed schizophrenia with a strong genetic predisposition.
Welcome to Highlights of Frontiers of Schizophrenia, a special session held at the 130th Annual APA Convention in Toronto, Canada. For this special session, made possible by a grant from Smith, Kline and French Laboratories, a panel of renowned physicians gathered to mark the 25th anniversary of the first clinical trials of chlorpromazine in psychiatric patients. From Paris came Dr. Pierre Deniker, from Sweden, Dr. Arvid Carlson, from England, Dr. John K. Wing, and from the United States, Dr. Seymour S. Kety. They summarized the major advances in schizophrenia research in the quarter century since neuroleptic chemotherapy was introduced, and they surveyed contemporary research in genetic, biochemical, and social factors of the disorder. They also indicated new directions for future study of what has been called mankind's most baffling mental condition. Dr. Robert E. Jones, clinical professor of psychiatry at Jefferson Medical College in Philadelphia, and editor of the Transactions and Studies of the College of Physicians of Philadelphia, opened the program.
Our program this afternoon, Frontiers of Schizophrenia, is a celebration. We are celebrating the 25th anniversary of the introduction of chlorpromazine into psychiatry, and therefore the birth of psychopharmacology. The effects of chlorpromazine and other medications related to it on the care of psychiatric patients and on research in brain chemistry have been so important to our branch of medicine that the American Psychiatric Association believes that a celebration is in order. This fantastic achievement was the work of many hands and minds. Our program this afternoon, then, honors all these pioneers, both the chemists and the clinicians who introduced chlorpromazine. The first in a series of psychotropic drugs, chlorpromazine markedly improved the lives of millions of human beings, reduced the population of psychiatric hospitals, stimulated an extraordinarily fruitful era of biochemical investigation, and opened the prospect of conquering mental illness. The first producers of chlorpromazine in the United States, Smith, Kline and French Laboratories, have graciously sponsored today's special session. On behalf of the association, I want to thank Smith, Kline and French for their generosity. Because chlorpromazine was found to be so remarkably effective in reducing the pain of schizophrenic illness, we've decided to focus today on schizophrenia. We plan to review present knowledge and to take a look into the future at new directions for research.
Dr. Pierre Deniker was then called upon to present the first paper. Dr. Deniker is professor of psychiatry at the University of Paris and head of the University Clinic at the Hospital of St. Anne. With his associate, Jean Delay, he first introduced the world to the role of chlorpromazine in psychiatry. Newly honored as a distinguished fellow of the APA, Dr. Deniker chose as his topic the impact of neuroleptic chemotherapy on schizophrenic psychoses.
Since the introduction of chlorpromazine in therapy, this drug has had many brothers and sisters, offsprings and cousins, which belong to more or less distant families. It is not their chemical similarities that characterize the member of all those families, but rather their similar properties, in spite of their structural differences. Those characteristic properties, which have been described as soon in 1957 from the similar action of CPZ and reserpine, can be nowadays summed in two terms. One, an activity which reduces various psychotic mechanisms, which is also called antipsychotic activity, and second, the ability of inducing special neurologic effects of the psychomotor, extrapyramidal, or vegetative types. Today, dozens of varied compounds meet this definition. In a single chemical group, the agents that have both properties are really neuroleptic or major tranquilizers. The compounds from the same family that do not have neurological effects generally lack antipsychotic action. German authors have noted an exception, that of clozapine, which is effective in psychosis and seems to lack extrapyramidal effect. In fact, clozapine is not an exception. The profile of this compound is close to the one of the aliphatic phenothiazine, such as levomethpromazine, which owns powerful neurovegetative action and very few extrapyramidal effects, together with a strong sedative and antipsychotic activity. The definition of neuroleptic drugs has pharmacoclinical correspondence, such as the induction of animal catalepsy and antagonism to the different apomorphine-induced effects, which are accurate tests that have enabled to screen and discover many new compounds. The continuous advance of neurochemistry in the cerebral amines field owes much to the study of the effect of neuroleptics on some neuronal structures. Today, they help to a better understanding of the action mechanism of the varied drugs that lead to similar effects by different processes. Then we study the data of controlled researches conducted with different neuroleptics in the population of patients qualifying as schizophrenics, and that for a long period we can note that the therapeutic effects are somewhat comparable, making the differentiation of the tested agents rather difficult. It may be true that their actions are qualitatively similar. Decrease of excitation, lessening of the delusive production and hallucination, improvement of the relationship and the chosen activity. While the different antipsychotic activity of neuroleptic are somewhat qualitatively comparable, they vary according to the dosage, to the structure of the compound, and also to the patient's own reactivity. The minimal and the maximal dosage vary from one compound to the other. Moreover, the various therapeutic activity are qualitatively different from one compound to another and from one chemical family to another. Thematically, it can be said that neuroleptic chemotherapy acts in various manners. One, a reduction of acute schizophrenia episodes. Two, a more or less complete prevention of relapse. Three, a longer delay between evolutive crises with a fragmentation of the evolution of the psychosis. Four, a decrease of the delusive and hallucinatory activities. Five, a better affective participation and social adaptation. In the whole, we can say there is a reduction of the intensity of the psychosis and the decrease of its evolutive potential. However, the effectiveness of chemotherapy varies according to the clinical and evolutive forms of schizophrenia. In the following lines, we consider three possibilities. The first and the most favorable one is represented by the psychoses that are treated early and that have mild evolutive potential. Without treatment, we can note a spontaneous remission in 20 to 60% of the case after an acute initial episode. Then the morbid persists with phases that are more or less active. In this case, the mental state does not return to normal. On the contrary, it aggravates with every outbreak. The same evolution when the psychosis is actively treated lets us note faster resolution of the initial episode. During the remission phases, things happen almost identically. If the treatment is interrupted, a relapse will occur, but it will stop if treatment is started again. In the favorable cases, there will be mildly severe psychotic episodes and wide interval. The second possible case, and the most severe one, is represented by the progressive form of schizophrenia that develops as whole towards a state is both defective and autistically delusive. According to the effectiveness of the chemotherapy and to the patient reactivity, we can note breaches or notches in the evolutive diagram. From the value of those breaches or notches, or from each case, we can obtain either a fragmentation of the evolution or simple inflection of the psychosis. The third case is represented by the phasic schizophrenia that's developed by outbreak, which, when adding one to another, each time cause the severity of the psychosis to increase. In this case, also we can obtain a fragmentation of the psychosis depending on the effectiveness of the treatment. But along with the evolution of the illness, the schizophrenic residue increases, even if we can obtain a decrease of the symptomatology on the whole. Naturally, we are aware of the summary character of those diagrams and of the lack of consistency of some notion such as evolution, morbid potential, or of psychosis, and the own reactivity of the patient. The evolutive potential is an abstract notion issued from a comparison of cases which look similar when treated or not. On the contrary, the concept of reactivity is a concrete constatation that we make by comparing several treatments in same patients without being somehow able to explain every time why this one drug is more active than this other. We have noted that neuroleptics are able to modify the severity and the evolutive action of schizophrenic psychosis while being not specific towards those psychoses.
In his closing remarks, Dr. Deniker called for heightened neuroleptic research efforts to further advance the therapeutic gains of the past 25 years. Finally, he said psychiatrists must remain eclectic in their choice of therapy, and that the best results can usually be obtained with combinations of medication, psychotherapy, and sociotherapy. The next speaker was Dr. Arvid Carlson, professor and chairman of the Department of Pharmacology at the University of Gothenburg in Sweden, where he has been examining the multiple biochemical phenomena which happen at brain synapses. His recent work with neurotransmitters has led to the advance of the dopamine hypothesis of schizophrenia and has helped to delineate biological mechanisms which may be involved in the schizophrenic process. His topic was antipsychotic drugs, neurotransmitters, and schizophrenia. Dr. Carlson began with a review of early work with reserpine, brain amines, and dopamine turnover, and then discussed the antipsychotic action of alpha-methyltyrosine and the mimicking of paranoid schizophrenia by amphetamine and alpha-methyl-dopa. He then went on to delineate the action of apomorphine on the motility of mice and suggested that in addition to the classical postsynaptic dopaminergic receptor, there might also be a presynaptic receptor, or as he called it, an autoreceptor, which is responsible for local feedback control of transmitter synthesis.
Coming back to this problem of the mode of action of apomorphine, I think we have to suggest that part of the inhibitory action of apomorphine could be due to activation of these presynaptic inhibitory autoreceptors. And in order to account for our findings, we would have to suggest then that small doses of apomorphine preferentially activate these autoreceptors, and that would explain why these small doses of apomorphine cause a paradoxical inhibition of behavior. Now, does this have any clinical relevance? This could very well be the case. There are studies showing that in choreatic patients, if apomorphine is administered, there is a paradoxical decrease in the choreatic movements. Also, a paper has been presented at this meeting by Dr. Taminga that apomorphine is capable of reducing schizophrenic symptomatology, even though, of course, the whole thing, I think, still should be regarded as preliminary, even though perhaps we should also add that there are quite early publications, even before the era of modern psychotropic drugs. There are reports that apomorphine has an antipsychotic action. Perhaps the heart and the pacemaker and the conduction system of the heart can be looked upon as a very simple model of those structures that we now discuss. That's the striatum and the limbic system. We can talk about hypofunction of this pacemaker conduction system of the heart. We can talk about that will lead to bradycardia. Hyperfunction will lead to tachycardia, of course. But there is another element that may come into the picture in case of hyperfunction, and that is that ectopic pacemakers can be activated, and then we will have arrhythmia, but for the sake of conformity of this slide, I call it here dysrhythmia. Now, suppose that we have similar conditions in the brain. So in the striatum, we may speak about hypofunction. That will be bradykinesia, as in Parkinson's disease. We could have tachykinesia, and in the case of Huntington's chorea, for example, we have dyskinesia. And maybe these crazy movements that are produced in chorea, maybe they are induced by ectopic pacemakers that are operating somewhere in the striatum. And we can go on then to the limbic system and talk about hypofunction. That would be bradyphrenia. We might have that in depression. Tachyphrenia, perhaps in mania. And if the integrative function is lost through the appearance of ectopic pacemakers, we would perhaps get crazy, now and this time not crazy movements, but crazy thoughts that would lead to dysphenia, or if you wish, schizophrenia. Well, if we go on, we can look at the various endogenous agonists that are involved, and it's interesting that in all these three cases, catecholamines are very important excitatory agonists. Even though they are not identical, in the heart we are dealing with noradrenaline and adrenaline, and in the brain with dopamine and noradrenaline. We also have, for example, acetylcholine comes in all three cases as an inhibitory agonist. And there are other parallels one could go into, but We also have to worry about, of course, not only the amines, but also amino acids, peptides, hormones. It's a very complicated interplay of actions. Now, if we go back to the heart and look at the antagonists, synthetic antagonists, we know very well that beta-adrenergic blocking agents are very potent in antagonizing this kind of arrhythmia induced by ectopic pacemakers. But that certainly does not justify us to conclude that hyperfunction of noradrenaline or adrenaline is the single cause of this type of disturbance. If we go to the striatum, we know that neuroleptics, that is dopamine receptor blocking agents, they are effective in antagonizing and alleviating dyskinesia, as in Huntington's chorea. Certainly, we are not entitled from this to conclude that dopaminergic hyperfunction is a primary cause of Huntington's chorea. Rather, there is evidence suggesting that we are dealing with a deficiency in GABA. So all this ends up, I think, with a word of caution that when we speak about schizophrenia, in spite of all the evidence that dopamine functions are involved in antipsychotic action, when we come to the primary role of dopamine in schizophrenia, we have to be rather cautious, I think. We know that homovanillic acid in the cerebrospinal fluid is not elevated in general in schizophrenia. If anything, it looks as if there is a trend to a decrease. So that would argue against a general increase in dopaminergic activity in the brain. We also, there is published evidence that monoamine oxidase, total monoamine oxidase activity is not deficient in schizophrenia, and there's similar evidence for catechol-O-methyltransferase activity. But still, we have to consider the possibility that there is a deficient monoamine oxidase in a specific compartment. It could be very small, but still very strategically important compartment, for example, in the monoaminergic neurons themselves. And if this is so, then this could involve not only dopamine, but also noradrenaline, adrenaline, and 5-HT. We also have to consider the possibility of a deficient catechol-O-methyltransferase in specific compartments, and this could then involve noradrenaline and adrenaline in addition to dopamine. Here we have to consider a deficient transport of transmitter from the synaptic cleft into the pre- or postsynaptic cell. That also would lead to an increased dopaminergic activity. Finally, down here we still have two more alternatives: increased receptor sensitivity, and at the meeting of the Association of Biological Psychiatry, Dr. Zeman presented some very preliminary data that would of the binding studies that would favor the hypothesis that in schizophrenia, in the brains of schizophrenic patients, you have an increased number of dopaminergic receptors. So this is certainly one of the remaining possibilities that has to be looked into. Finally, we can not disregard the possibility that there is a small but very important dopaminergic pathway where you, as a matter of fact, have an increase in firing, release, and metabolism and turnover, even though the pathway is not big enough to show up in the shape of an increase in homovanillic acid in the cerebrospinal fluid. Thank you.
Our program continues in just a moment. First, here's a brief message from SK&F.
Primitive man has many explanations of mental illness: voodoo, evil spirits, black magic, an ancestor's curse. He also has many remedies: herbs, incantations, secret ceremonies. In our culture, there are also many explanations and treatment methods for mental illness. But despite lack of agreements over etiology and modes of therapy, one thing remains certain. Stelazine, trifluoperazine hydrochloride from SK&F Co., remains a first choice for therapy in a wide range of schizophrenic patients. Stelazine effectively controls hallucinations, delusions, anxiety, and other schizophrenic symptoms, and can help facilitate other modes of treatment, such as psychotherapy. It apparently works to activate withdrawn, apathetic, or detached patients. In addition, anxious and overactive psychotic patients can also benefit from the antipsychotic activity of stelazine. And since stelazine usually does not cause excessive sedation, overactive patients can channel their energy into constructive therapeutic outlets. For the majority of patients who are neither withdrawn or overactive, stelazine provides control of major psychotic target symptoms and offers the convenience of easy-to-take BID dosage. In a wide range of psychotic patients, stelazine effectively helps in the return to reality. Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using this or any other phenothiazine in patients who are hypersensitive to these drugs. Physicians should be alert for neuromuscular reactions, including tardive dyskinesia and other adverse effects associated with phenothiazine therapy. Dosage requirements of patients on high-dose, long-term therapy should be evaluated periodically. Before prescribing stelazine, please consult the accompanying complete product information. Stelazine, a first choice for therapy in a wide range of psychotic patients.
Now rejoin Frontiers of Schizophrenia. Third speaker on the program was Dr. John K. Wing, professor of social psychiatry at the University of London and director of the Social Psychiatry Unit of the London Institute of Psychiatry. Dr. Wing spoke on the social context of schizophrenia. He outlined several areas where substantial progress has been made in the past 25 years, including the reliability with which psychiatrists can describe and recognize conditions needing treatment, the recognition of proximate social causes of schizophrenic breakdowns, the interaction between social and pharmacologic treatments, and the management of schizophrenia.
The second area where considerable progress has been made is that of the social causes of the characteristic acute and chronic syndromes. The simplest way to study these is to look for the immediate effects of varying social conditions. It's been very well documented, for example, that some patients living in a sheltered environment relapse very quickly when they're exposed to a program of rehabilitation that asks too much of them. In other words, social pressure, even when well-intentioned, can be harmful. Another kind of social pressure was described by Brown and Burley, who showed an increase in the frequency of certain life events compared with control groups during the few weeks immediately before the first onset or an acute relapse with the characteristic schizophrenic acute syndromes. Other studies have shown that patients who return home after discharge from hospital to live with a relative who is hostile, critical, or emotionally over-involved tend to have a very high relapse rate compared with those whose relatives are more accepting and emotionally neutral. These three very different kinds of social precipitants have in common the fact that they occur in close contiguity to the onset or the acute relapse, and because there has been for a long time a theory that the relatives of schizophrenics have had a malign effect on them a good deal longer ago than that. I think most of the hard evidence is concerned with immediate precipitants of schizophrenia, and we're on very dangerous and uncertain territory when we start looking for the very long-term and original social causes. Very few empirical studies, in fact, have really tested this hypothesis, and the methodological problems are immense. As for the really passionate advocates of various forms of the early environmental model of causation, it's very difficult to understand the strong motivation to believe such theories in the absence of a substantial body of evidence in favor. Like the Red Queen in Alice Through the Looking Glass, some people seem to be able to believe 6 impossible things before breakfast. Now, reverting to the very different kinds of factor that do seem to be clearly and immediately related to relapse or first onset, what they seem to have in common is a degree of social overstimulation. Now, these are very general terms, of course. Other social causes of schizophrenic symptoms seem to work in a very different way. The clinical poverty syndrome, for example, tends to become much more pronounced under conditions of social understimulation. The classical example is the back ward of the old-fashioned mental hospital, where severely disabled schizophrenic patients with little capacity for spontaneous communication were left to their own devices and spent a very large proportion of their waking day doing absolutely nothing. They became more withdrawn, more underactive, more apathetic under these conditions. And within limits, those effects can be reversed. And of course, we are talking about symptoms which Bloiler thought were fundamental to schizophrenia. An increase in the richness of the social environment tended to lead to a decrease in the social withdrawal syndrome. That result, of course, is not only true of the back wards. It's been found that schizophrenic patients are vulnerable to such effects wherever they're found, in hostels or hotels, group homes, day centres, sheltered communities, centres for the destitute, lodgings, or even in the patient's own home. In one 5-year follow-up study, it was found that amongst those who were unemployed at home, the length of time spent doing absolutely nothing was of much the same order as in long-stay patients in a hospital with a poor social environment. If these studies are accepted as providing a basis for rational social treatment, there are 2 major problems. One is the reduction of an excessive level of social withdrawal and other associated behaviors by enriching the social environment without provoking an acute relapse. And the other is the reduction of an excessive level of social stimulation without encouraging undue dependence. I won't go into the details of the treatments based upon those, but go on to the question of the interaction between social and drug treatments, which I think is a very fundamental question for us now. In research on long-stay schizophrenic patients, there have been many indications that drug treatments and social treatments are not alternatives, but must be used to complement each other. The better the environmental conditions, the less the need for medication. I'm speaking generally. The poorer the social milieu, the greater the need, or at least the greater the use of drugs. A similar generalization can be made, although the details are different, about the best methods of handling acute breakdown. If phenothiazine drugs work, at least in part, in general terms, by reducing a high level of physiological arousal, they should be most effective in conditions of social overstimulation, and there's some evidence that this is so. It's been suggested that patients who live in low-emotion families can avoid relapse, except for the operation of accidental stresses, even without taking preventive medication. Tarrier and his colleagues in unpublished work have recently shown that schizophrenic patients sitting quietly by themselves in their own homes have a high arousal level, as measured by skin conductance, for example. If a high emotion relative enters the room, there is no change in this high arousal level. If a low emotion relative enters, the high arousal habituates towards normal. This work needs to be repeated, but if it holds true, it suggests that some relatives have a calming and supporting effect, similar to the protective effects of a good hospital or a good hostel or a good therapist. On the whole, the need for medication is minimized when the patient is living in optimal social surroundings. And the optimum environment is structured with expectations geared precisely to the level of performance that the patient actually can achieve, or perhaps a little above, but with supervision that is not emotionally over-involved. Complex decision-making is particularly difficult for patients and tends to rouse their anxiety or their withdrawal. control of the level of social stimulation must be left to some extent in the patient's hands. A relationship of trust and confidence, whether with relatives or with professional staff, is most likely to develop when these conditions are optimal. I think the concept of the management of a chronic physical disease is very appropriate to schizophrenia. One has to consider this from the points of view of the patient and the patient's relatives and others in the immediate social environment on whom his well-being and his livelihood may depend. Each group sees a different set of problems and often fails to appreciate the difficulties faced by others. The principles of management in schizophrenia are relatively simple, but they require the acquisition of skills that some psychiatrists, some nurses, occupational therapists, social workers do not now possess. And above all, they require a willingness to learn from patients. The same is true of the relatives. But here, there is a somewhat different problem, because part of the peculiar difficulty in managing schizophrenia is that it lies somewhere between conditions like blindness, which, although they are severely handicapping, don't interfere with an individual's capacity to make independent judgments about his own future, and conditions like very severe mental retardation, in which it's quite clear the individual will never be able to make such independent judgments. There's quite frequently a fluctuating degree of insight and of severity. And in some cases, of course, the fluctuations appear to follow no obvious pattern. They're quite unpredictable, and environmental circumstances seem unrelated. But the fact that these impairments are invisible makes the problem even more difficult, since neighbors and friends, and even sometimes professional advisors, deny their existence altogether. That's why skills counseling, which means much more willingness by professionals to learn from relatives and patients, is of the essence of good management. Our attitudes to cancer have changed fundamentally during the past decade. Opinion leaders are willing to say that they've been treated for it and that they can live with it. This is not yet true of schizophrenia. Doctors themselves sometimes are still frightened of the word. Because the most effective methods of management and the services to back them up are not yet universally available or known or applied, it's rare for the condition to be frankly and realistically discussed. Public opinion remains ill-informed and prejudiced. But just as the results of treatment have dramatically improved during the past quarter of a century, so the application simply of our present knowledge could produce a further substantial step forward, and we would find that public opinion moved forward with us. Thank you.
The final speaker was Dr. Seymour S. Kety, professor of psychiatry at Harvard University and director of the Psychiatric Research Laboratories of Massachusetts General Hospital. Dr. Kety discussed recent evidence bearing on the interaction of genetic and environmental variables in the group of schizophrenias. He first presented data from twin studies which indicated that genetic factors operate in the transmission of schizophrenia, producing a concordance rate of 40 to 50% in monozygotic twins. He then discussed evidence which indicates that schizophrenia can be differentiated from other mental illnesses on a genetic basis, and that it is not a homogeneous syndrome genetically. The methods by which the environment interacts with genetic vulnerability to produce schizophrenia was the next part of his presentation.
There is no doubt that environmental factors are crucial and important in the genesis of schizophrenia. And the best evidence that I know of for that is that in all of the studies of monozygotic twins, the concordance rate is never 100%, and in the most carefully conducted and well-controlled studies, the concordance rate is 50%, which means that genetic factors can't possibly account for schizophrenia entirely, but that something in addition to genetic factors must be operating in order to produce the illness. What can these environmental factors be, and how may they be interacting with what kind of genetic vulnerability? One can imagine that there could be a genetic deficiency in certain transmitters, or in enzymes that produce them, or in neurons, or in nerve endings, or in receptors, affecting certain psychological potentialities of the individual or psychosocial potentialities of the developing child, such as attention, exploratory activity, reward mechanisms, learning, and the development of normal and appropriate affective concomitants, an appropriate response to stress, vulnerability to psychosocial influences, either positive or negative. These factors, which I have not just taken out of a hat, are related in some vague way to what we know at the present time to be some of the psychological mechanisms in which the neurotransmitters operate. And it is not unreasonable to imagine that neurotransmitter deficiencies could result in a deficiency in these psychological areas, which are in fact deficient in schizophrenia, and which could, if deficient early enough on, cause a crescendo of inappropriate development, which would result in a more intensive kind of reaction, which we would then perhaps call schizophrenia. Now, the psychosocial influences acting upon these genetic expressions would, of course, be those that could be found in the rearing of children, and here we would have all of the hypotheses about child rearing, which are certainly plausible hypotheses. Much data has been acquired which is compatible with those hypotheses, but I am not sure that those hypotheses have yet been validated in any convincing way. And while we are thinking of those variables, we mustn't lose sight of a wide variety of other environmental variables which are certainly operating upon the developing child and which may also be important in the etiology of schizophrenia. Birth injury is the first of these that comes to mind, and there is evidence which is compatible with the hypothesis that birth injury may be an environmental factor which, acting upon certain genetic vulnerabilities, can produce schizophrenia. Deficiencies in some of the transmitter systems could be aggravated by neonatal asphyxia, for example, or there may be other kinds of birth injuries that have nothing to do with these transmitter systems, but simply affect certain parts of the brain which are then capable of producing the symptoms of schizophrenia in the absence of gross neurological defect. Also compatible with the possibility that birth injury operates is the well-known observation that there is a gradient for schizophrenia according to socioeconomic class, with the lower socioeconomic classes showing a considerably higher prevalence of schizophrenia. However, it is interesting that that gradient is not a universal gradient, but according to Cohn, occurs most clearly in large cities, as if there were something about the life of the lower socioeconomic classes in large cities which distinguishes them from the lower socioeconomic classes in villages, towns, and in the countryside. Now, we know that the lower socioeconomic classes in large cities live in slums. We know that obstetrical care may be defective there. We know that there are many psychosocial stresses. We also know that there's a great deal of congestion and a lack of hygiene. And all of these factors must be taken into consideration if we are going to try to account for this socioeconomic gradient with schizophrenia. Recently, Dennis Kinney, a young psychologist, came to us with a very ingenious idea that since our schizophrenic adoptees fell into two classes, those who had a strong genetic component as determined by the prevalence of schizophrenia in their biological relatives, and another, about 50%, who had a very weak genetic component because there was no schizophrenia in their biological relatives, he felt that this made it very interesting to try to compare these two groups in terms of hypothesized environmental variables, because if a person develops schizophrenia without a strong genetic predisposition, then one would expect that his environmental factors would have to be especially strong. One of the things that he has found is that those adoptees who became schizophrenic without a known genetic load in their biological families have a very high history of birth injury or brain injury soon after birth, encephalitis, concussion, and so forth, as compared to the probands who developed schizophrenia with a strong genetic predisposition. There are other environmental influences which we must think about, which could interact with genetic factors. Diet is one of these. Pauling has recently developed the rather ingenious hypothesis that there is a genetic deficiency in certain individuals which requires on their part considerably more daily dose of the essential vitamins than that which is required by other individuals. And the hypothesis that schizophrenia or some forms of schizophrenia may be the result of an inadequacy of one or another of these vitamin intakes in an individual who is genetically requiring more vitamins. Now, I say the hypothesis is interesting and plausible and imaginative. In fact, it has been actually demonstrated and validated in certain neurological defects. Rosenberg has described a whole class of genetic neurological defects in which the primary genetic contribution is an inability to utilize particular vitamins. And these neurologic diseases can be cured by large doses of one or another of these vitamins. In the case of schizophrenia, there is no acceptable evidence that I'm aware of that any of the vitamins which have been suggested as being deficient in schizophrenics, vitamin C, nicotinic acid, a whole variety of other vitamins, is actually defective in schizophrenics, or, in fact, that a regimen consisting of very large doses of vitamins will be effective. What other environmental factors should we think of? There have been many reports of an excess of births of schizophrenics in the cold winter months. Dennis Kinney wanted to know about the birth dates of our 34 adoptees in the greater Copenhagen sample because he wanted to test this hypothesis, and I scoffed at that idea because I knew that it had required hundreds and hundreds of schizophrenic cases to show this very small but significant excess, and the chances of finding it in 34 were trivial. However, when Kinney compared the birth dates of those in our sample with a strong genetic load with those in our sample with a weak genetic load, he found that those who became schizophrenic with a weak genetic load had an 80% prevalence of being born in the cold winter months. Now, the cold winter months are interesting. In Sweden, they seem to be associated with increased birth trauma. However, in many countries, there is also a peak in the incidence of certain viral diseases in the cold winter months. There is also the possibility that autoimmune factors may interact with genetic predispositions, especially in the HLA antigen group, and there have been a few studies to date which suggest a slight association between schizophrenia and particular HLA antigens.
Now, here's a brief message from SK&F.
India, land of yoga, meditation, and tradition. A society which for thousands of years has placed a high value on introspection, introversion, and emotional control. It's not surprising, then, that the majority of schizophrenics in India are withdrawn. In fact, catatonic rigidity, negativism, and stereotypy are also quite common among Indian psychotics. In our culture, though, symptoms of agitation, anxiety, and even violence are often found in schizophrenic patients. It is for these patients that Thorazine, chlorpromazine SK&F, is especially useful. Thorazine offers effective control of psychotic symptoms, including hallucinations, delusions, and anxiety. It calms agitated hyperactive patients and helps improve their disordered thoughts and perception. Thorazine helps you establish a functioning relationship with patients. From psychiatric emergency through maintenance therapy, Thorazine, with 18 dosage forms and strengths, allows you to tailor medication to the patient's needs at every step of the way.
Thorazine, chlorpromazine, is contraindicated in comatose states, in the presence of large amounts of CNS depressants, and in the presence of bone marrow depression. Avoid using in patients hypersensitive to phenothiazines. Caution patients about activities requiring alertness. Avoid concomitant use with alcohol. Use cautiously in persons with cardiovascular, liver, or chronic respiratory disease, or with acute respiratory infections. Aspiration of vomitus is possible. Thorazine may prolong or intensify actions of CNS depressants. Patients on high-dose long-term therapy should be evaluated periodically for possible adjustment or discontinuance of dosage. Physicians should be alert for extrapyramidal system side effects, CNS depression, hypotension, hematologic effects, liver toxicity, and other adverse reactions associated with phenothiazine therapy. Before prescribing Thorazine, please consult the accompanying folder for complete product information, including indications, contraindications, warnings, precautions, and adverse reactions.
Thorazine, because a calm schizophrenic patient is more receptive to therapy.
Thank you for joining us for highlights of Frontiers of Schizophrenia, a special session of the 130th Annual APA Convention.